So today we're going to be looking into the TRICORDER study from researchers at Imperial College London. It's been all over the news, reported in various outlets, equipping GPs with an AI-enabled stethoscope and reporting some eye-catching results for detecting heart disease. So let's get straight to it. So what's the problem the researchers were looking to solve here? The stark reality is that we diagnose heart failure dangerously late in the UK, and they report how unacceptably 80% of new diagnoses are only made after an emergency hospital admission, despite most patients having seen their GP with symptoms beforehand. So the TRICORDER study is designed to tackle this head-on by testing if an AI-powered stethoscope can help primary care clinicians detect heart failure, atrial fibrillation, and valvular heart disease far earlier than it is currently happening in the community. So the big idea is to augment one of the most familiar tools in medicine, the stethoscope, with a validated AI algorithm to turn a routine physical examination into a powerful screening opportunity. So it's a compelling goal with a genuine, real issue it's trying to address, but the success hinges entirely on execution, so let's dig a bit deeper. So the headline results were presented at a major cardiology conference, and they sound very impressive. Reports claim that patients examined with the AI stethoscope were more than twice as likely to be diagnosed with heart failure and over 3 times as likely to be diagnosed with atrial fibrillation in the trial period. So on the surface, it looks like a huge win. And the central idea depends on this AI tool driving better diagnoses. However, we have to question cause and effect here. Was it truly the AI stethoscope itself that led to these improvements, or could this be a Hawthorne effect where being monitored and in a trial changes behaviour? And it's slightly difficult to know that. The results that we've seen are all media reports of a conference presentation, and we don't yet have peer-reviewed published research to be able to scrutinise it fully. So the key question in my mind is whether being in the trial simply prompted GPs to perform more standardised diagnostic tests like BMP blood tests on a patient with breathlessness, fatigue and ankle swelling. So kind of the protocol and the study specified that anyone with these 3 symptoms would be examined by the AI stethoscope and then have further testing. And so we need to know, is it the AI stethoscope itself that was leading to these effects, or just GPs being part of the study testing more people with symptoms, which could have led to higher rates of diagnosis. So to untangle this, we need to know the testing rates before versus after the trial started in both the intervention and control groups. Without that data available, we can't be sure it was the AI was actually the cause of the increased pickup rate, rather than just a catalyst for better adherence to existing guidance. And furthermore, reports also suggest that 70% of GP practices, given the smart stethoscope, stop using them or use them infrequently after 12 months. So this raises questions about the long-term feasibility and practicality, which I'm sure the researchers are kind of looking into and aiming to address. So what I can see is that the protocol is published online, and the study design is methodologically extremely strong. It's a large-scale, pragmatic, cluster randomized controlled trial, which is a gold standard for this type of question. It's a very pragmatic design. But the results themselves they've reported at a conference and through press releases aren't in peer-reviewed publication. So the kind of widespread media reporting of these non-peer-reviewed research is building a bit of hype without allowing for proper scientific scrutiny. And we need to be able to scrutinise things before such widespread reporting. And I imagine the researchers themselves wouldn't have had any idea that their work presented at a conference would be reported so widely. So this isn't a comment in relation to them. It's more the kind of it's an indication how the media are primed to jump on any interesting story in the health-related AI space. It'd be helpful. We need to know things like the average number of AI recordings per practice per month, how many alerts were generated, how many were acted upon, what were the diagnostic testing rates, and positive and negative predictive values of both tests in both arms of the trial. And this is the kind of granular data combined with the primary outcome analysis that will allow us to properly scrutinise the claims and get to the bottom of what's driving any effects. So the core idea is incredibly strong. It addresses a critically important problem, the trial design's excellent, and the headline results are tantalising. But its success now depends entirely upon the release of detailed peer-reviewed data that can withstand widespread scientific scrutiny. It's a potentially game-changing application with real impact in primary care. But for now, we need to wait for the evidence to catch up with some of the coverage that there's been.